Good morning, everybody. Today we are going to discuss two important issues. First, the renal syndrome, and second is acute GN. Let us start with renal syndromes. But before starting, we have to know some basics about the anatomy of the kidney, which is present in the paravertebral lateral posterior abdominal wall, and the right kidney is one space lower than the left kidney, as shown here, because of the position of the liver, and it occupies each the three spaces, three vertebral spaces. The right kidney starts from L1, while the left kidney starts from T12. And the dimensions of the kidney range from 12 as a length, 6 the width, and 3 centimeter as a thickness, and this is the average. It is surrounded by the fibrous capsule and the perinephric fat, and the fibrous capsule is the only sensitive structure in the kidney. The hilum contains the vessels of the kidney and the pelvis of the ureter. And this is shown clearly in this cut section of the kidney. I would like to highlight in here what is shown in the parenchyma. It is divided into two parts. The outer part is a cortex. This is a cortex. This is a cortex. And the inner part is a medulla. The medulla is composed of these triangular or pyramidal shaped structures, which are the pyramids, and the interpyramidal columns in between. There are around 9 to 11 pyramids. And the cortex and medulla are delineated by an imaginary line which passes along the base of the pyramids. This is the line which is shown here. Each apex of the pyramids enter into the minor calyces, these are the minor calyces coalescing together, making the major calyces, and thence the pelvis of the ureter. The vascular supply of the kidney is unique. It's composed of two circulations, as I will show now just in the next few seconds. So we are starting from the renal artery coming from the aorta, and they divide into branches called segmental branches. And these segmental branches pass between the pyramids. They are dividing into smaller branches pass between the pyramids. They are called interlobar branches, passing between the lobes of the kidney, which are other names for the pyramids. And then each interlobar branch divides when it reaches the base of the pyramids into two branches passing on the base of the pyramids. These are the arcuate because they look like an arch. And then from these arcuate curved branches, there are perpendicular smaller branches which are called cortical radiate arteries because they are cortical in place and they are radiating from the arcuate arteries passing into the cortex, and they are end arteries. So when they are damaged, no more regeneration for these branches. And then from these arcuate arteries, there are multiple afferent arteries passing in to each glomerulus, which is an important part for the nephron, which is the basic unit for the kidney. And then the afferent arterioles pass into the glomerular capillary tuft. And getting out of the glomerular capillary tuft, the efferent arterioles. And this is a unique circulation that in this circulation, the capillaries is fed by an arteriole, and it is drained by an arterioles, not a venules. And this is unique for the kidney. Why? So as the purpose for this that to to create a huge intraglomerular pressure, because the pressure inside, beyond or in front of this glomerular capillary duct is huge, because it is an arterial pressure, and this creates a high pressure for the sake of the filtration inside this glomerulus. Again, the efferent arterioles pass into two types of capillary plexus, channels, I mean, from the efferent, I will show to you now. It passes into either peritubular capillary or vasa recta. I will just explain within 1-2 seconds. And then the reverse of the veins. This is the arcuate veins, the cortical rigid veins, arcuate veins, interlobar veins, and the segmental veins, and the renal veins, and the infravena cave. What about the story of these? I will show you now. As we show here, all the glomeruli are placed in the cortex, but all nephrons or glomeruli are cortical, but those who are near to the medulla are called juxtamedullary cortical glomeruli, or sometimes juxtamedullary glomeruli, and that's all. And the rest will called cortical glomeruli. Both are cortical, but these are named cortical, that's say not juxtamedullary type. When there is the efferent arteriole getting out of this glomerulus, which is juxtamedullary, they will pass along the loop of Henle, and they are the vasa recta. They are responsible for the countercurrent mechanism for the renal tubule. While the efferent coming out of the cortical glomeruli, they will pass into peritubular capillary. Okay, so we have two capillary plexus in the circulation of the kidney, as you show now. This is another one glomerular capillary, and this is another capillary plexus, which are the peritubular capillary. This is another unique issue for the circulation in the kidney. Okay. As we know, all the nephron, which is the basic unit of the kidney, is composed of a vascular part, which is the glomerulus, which we just talked about, and the feeding is the afferent, and the output is efferent arterioles. And the second part is a tubular part. We all know the tubule of the kidney, the most expanded part is the Bowman's capsule, and then the proximal convoluted tubule, and then the loop of Henle, and then the distal convoluted tubule, which come here, which is the shaded part, which come near to each feeding glomerulus, and then the collecting tubule and the connecting ducts, and then this is the minor calyces. Okay, this is diagram is very beautiful diagram, will make you imagining that this is the cortex and the glomeruli lying here. This row can call the juxtamedullary glomeruli, and the rest are the cortical glomeruli. And this part is inside the purse. After this demonstration about the introduction for the anatomy, we just, when we are talking about the kidney, it's not one tissue. So we can conclude from that whenever there is affection of multiple tissue, there are multiple presentation as well. And these are the multiple presentations of the kidney called renal syndromes. So renal syndromes, which are talking about now, are the diseases or the presentations, the clinical presentations of different diseases of the kidney. Okay, because we have different tissues of the kidney. What are these tissues? We have the glomeruli, and when there is disease, there are glomerulonephritis or inflammation of these glomerulus, there will be glomerulonephritis. When there are affection of the renal tubules, and commonly they are associated with the interstitium because the tubules and the interstitium are very close to each other. So any affection will to one will affect the other. So we have, when there is a disease of those two structures, we have the tubulointerstitial nephritis. We hear about also the blood vessels of the kidney. We are talking just now about the blood vessel. When there is disease affecting the blood vessels of the kidney, so we have vascular diseases of the kidney. So these four main structures of the kidney, two of them are together. So we have three main topics or three main renal syndromes or another renal disease. So we have the group of glomerulonephritis, the group of tubulointerstitial disease, and the group of vascular disease of the kidney. When there is a fulminant disease affecting any of these four structures, we will have acute kidney. If there are chronic irreversible damage for any of these four structures, we will have CKD. So at the end of the day, we have these five group of diseases that may affect the kidney with a different structure. Are these the renal syndrome? No. The renals are the clinical presentations of these five diseases. The clinical presentation. When we are talking about renal syndrome, we are talking about the clinical presentation of these five diseases. What are these renal syndromes? There are some syndromes that are well defined and commonly affecting the patients with renal disease, and they are called together major renal syndromes. And there are other minor, which are hematuria of either asymptomatic hematuria or recurrent, going on and off, and proteinuria, asymptomatic or intermittent, getting on and off. So those are the four minor syndromes: asymptomatic hematuria and proteinuria, recurrent hematuria, and intermittent proteinuria. What about the major renal syndrome? These are very important. Again, I would like to remind you by the five diseases. First, the glomerulonephritis. The glomerulonephritis may present either by nephritic or nephrotic syndrome. And I will come now to know what is the difference and why GN may present with this in one day and with that in another day. Then the second is the tubulointerstitial disease of the kidney presentation. Then the vascular disease of the kidney and papillary necrosis. This is another presentation. And the AKI, which could be related to multiple causes. The most famous are the rapidly progressive GN. And lastly, CKD. So these six items are called the major renal syndromes. Back again to what we just discussing, why the GN may sometimes present with nephritic and some others with nephrotic. Coming here, we have to imagine the basement membrane of the glomerulus. So this is the basement membrane of the glomerulus, and the inside is a lining by the endothelial cells. And outside these basement membrane of the glomerulus, there is the visceral layer of the Bowman's capsule, which is composed by epithelial cells with food processes, so they are called podocytes. And this cut section demonstrate the food processes. These are the food processes. These blue parts, the food processes of the podocytes of the visceral layer of Bowman's capsule. In between these green parts are the slit diagram. If you if there are deposition of immune complex, because all the GNs are immunological mediated. At the end of the day, they're immune complex. If the deposition are here, the immune complexes are deposited here inside the basement membrane, let's say between the epithelial cells and the basement membrane, it's called subepithelial. Subendothelial. This is the endothelium, I mean. This is the red part, it's related to the red blood cells. So we imagine that they are near to the blood, so we draw it by red. So this is the endothelial. So if the immune complex are here, subendothelial, so the end result will be nephritic syndrome. On the other hand, if the food processes are deposited here, subepithelial, so the net result will be nephrotic syndrome. And this will be for all the scenario of GN, as will be discussed later. So we have the nephritic syndrome and nephrotic syndrome. And we'll take just 1 second or a few seconds for defining each syndrome, and we'll take each syndrome in a separate lecture, so don't be anxious about all these informations and knowledge. We'll repeat it again in a separate lecture, so just defining. So nephritic syndrome, when we have nephritic syndrome, we have 2H. I would like to remind you by these 2H. The first H is the hematuria, and the second H is hypertension. So nephritic, when you see nephritic syndrome, so remind these 2H, hematuria and hypertension. And it is, as we said, it is acute presentation of GN. Okay, and this is the dramatic, the most worst presentation for acute GN. It is acute nephritic syndrome, so it's a presentation of acute GN, not chronic at all. Nephritic all the time is acute situation, so it is acute GN, and the immune complex is deposited subendothelial, as we just said. Okay, what are the clinical presentation? 2H, hematuria and hypertension. The hematuria has a pathognomonic features. They have dysmorphic RBCs and red blood cells cause. So let us understand this topic. When there is inflammation of these basement membrane in the acute GN, because the immune complex is deposited inside here, there is thickened edematous permeable basement membrane, and the slit diaphragm between the pores inside the basement membrane will be somewhat wider, and this will allow the RBCs to escape out of the glomerular capillary tuft into these Bowman's capsule, but the space is still smaller than the diameter of the RBCs. So the RBCs, while it's passing through this hole, will be squeezed and will be dysmorphic. So the RBCs will have some bud like that, or two buds like that. It will become dysmorphic, bad morphology, abnormal morphology, and this is the name of dysmorphic RBCs. Okay. طيب, when these dysmorphic RBCs come here in the Bowman space, the pH will be different. It is an acidic pH, different from that neutral pH in the blood. So the hemoglobin inside, which is a protein, will coalesce together, will coagulate, I mean, and the RBCs will become rigid because there will be denaturation for its own protein. Okay, and if there are abundance of RBCs here, a lot of RBCs here, they will coalesce together to form a granular cast, a round cast, a spherical cast, and this is the round cast. It's composed of red cells, and all these red cells are dysmorphic. So we will find a round spherical cast, and it is composed of red blood cells. So we will have red blood cell cast and dysmorphic RBCs. This is very important. It's not a simple hematuria, but it is dysmorphic RBCs and granular red blood cell cast. Second is the hypertension. Why there is hypertension? Because there is some sort of relative ischemia for the glomerulus, because the inflamed basement membrane will diminish the space of the glomerular capillary tuft, and there will be less blood coming to the glomerulus, and it will sense it as ischemia, so there will be stimulation for the juxtaglomerular apparatus to elaborate renin, and there will be, at the end of the day, salt and water retention and hypertension. So for that reason, these are the two pathognomonic part of nephritic syndrome. Coming next to nephrotic syndrome, all of us know nephrotic syndrome while you are studying pediatrics. So I will revise just what are the stigmata of the nephrotic syndrome. We have three stigmata. First, nephrotic range proteinuria, which is greater than 3.5 gram per day per 1.73 square meter surface area, and this is the average surface area for an adult. Consequently, there will be hypoalbuminemia, and at the end of the day, there will be edema secondary to this hypoalbuminemia. So these are the three pathognomonic features for nephrotic syndrome, plus or minus hypertension, plus or minus dyslipidemia. Tubular interstitial disease of the kidney will be discussed in a separate lecture, a very long lecture. But the stigmata for the tubular interstitial disease, you will find there will be a lot of presentation, very variable presentation, but the pathognomonic for TIN will be proteinuria, but less than 1 gram per day, and as well as tubular cell in the urine, and white blood cell in the urine, as well as white blood cells cast and tubular cell cast. What does it mean? As we understand that the tubular interstitial disease, the disease will be in the tubule, not in the glomerulus. So there will be some cellular infiltration for acute inflammatory infiltrate. Will be white cells infiltrating the tubule, and there will be shedding of the epithelial cells, the tubular cell. If the shedded cells will coalesce together, this will form a tubular cast, a tubular shape cast. This this is a tubular shape cast, tubular, and is composed as well is composed of tubular cells. So they are tubular in structure, tubular in shape, like sausage كده, where it's composed of either tubular cell, as in this diagram, or by white blood cells. Uh, and these are the causes. We'll discuss all these issues later on. The vascular disease of kidney come next, and there are multiple presentations of multiple disease called collectively vascular disease of the kidney, because we have a long network of blood vessels. We have large vessels, so we have the atherosclerotic renal artery stenosis, fibromuscular dysplasia, Takayasu. We have medium-sized arteries. We have small arteries with all these diseases. We have veins, so we have possibility of renal vein thrombosis. So a vast diseases affecting the vascular network. AKI will be taken in a separate lecture, so I will not discuss more about this, because it will be discussed later on. And these are the causes. And CKD is defined as renal damage or diminution of the GFR less than 60 milliliter per minute per 1.7 square meter surface area for more than 3 months. 3 months. And we'll discuss later on the stages in another lecture. So this is the first part of the lecture, which are renal syndrome. So full stop, and we'll start another topic, which is acute GN. The first one lecture, we are talking about clinical presentation, which are the renal syndrome. Now we are talking about another issue. Acute GN is a pathological term. We cannot define acute glomerulonephritis except after taking a biopsy, and it will demonstrate acute inflammatory process affecting the glomeruli. Okay, so it is a pathological entity, and it may present with acute nephritic syndrome, as we mentioned. And this is the most dramatic, as we just mentioned. But there are another long list of presentations that may occur with acute GN. What are these presentations? Now we are shifting to another, the presentation of the acute GN. As we mentioned, it is acute GN, so it may present either by nephritic or nephrotic. And I drew this nephritic by red because this is the worst one. So for that reason, we will take it in a special color and special consideration, and a lot of debate about, a lot of concern about the nephritic syndrome, because it is dangerous and should be diagnosed well, to be treated well. Again, it may present with the minor renal syndrome. There might be asymptomatic proteinuria, asymptomatic hematuria, or recurrent hematuria. Again, it may be fulminant. So we may have rapidly progressive GN and acute kidney injury. And the acute glomerulonephritis may be a part of disease, systemic disease, as lupus, for example. So these are the multiple presentations of acute GN. Again, the most worst is the nephritic syndrome. So what are the causes of acute GN? So we have, as any cause, we have may have infection, either bacterial, viral, parasitic. We may have immunological disease as lupus, IgA Goodbuster. We may have vasculitis, vaginal polyarthritis, metabolic like amyloidosis. And all these will lead at the end of the day into immune complex. This is a multiple heat syndrome theory that will be discussed later in more advanced courses يعني. طيب again, if the patient will present by nephritic syndrome, because we'll concentrate now about nephritic syndrome because this is the most serious as we mentioned. So if your patient with acute GN present with nephritic syndrome, what will be the manifestation? The 2H, the hematuria, so it will reflect by red urine. And the sodium tension and the hypertension, so there will be puffiness of the eyelid, low lymphedema, and hypertension. And if it is of the most worst type, which is the RPGN, rapidly progressive glomerulonephritis, there may be uremic manifestation and oligoanuria. Okay. Type. And don't forget these pictures, the red urine with all grades of red, either smoky urine or pure red. We'll have this hypertension and we'll have this edema. Type. The RPGN is a much fulminating form of UGN. We have three names for RPGN. The first name is RPGN, rapidly progressive glomerulonephritis. Why it is called RPGN? Because the progression of the course is very fast. We may lose the renal function within very short period of time, days, weeks, or months. Again, the second name is the crescentic glomerulonephritis. This is the same pathology but with different name. Crescentic, why we are calling this topic sometimes crescentic? This is the same name, the same topic, I mean. Crescentic because the pathognomonic features of this disease in pathology is the crescent. What is the story of the crescent? This is a normal glomerulus on light microscopy. You will find the glomerular tuft is surrounded by an empty Bowman space. Because there are here the visceral layer of the Bowman's capsule, and this is the parietal layer of the Bowman's capsule. And in between there is a space, empty space, where there is the ultrafiltrate will come. Okay, if this space will be occupied by cells, so this will be the picture. Here there is no mover space. There are a lot of proliferating cells coming from the parietal layer of the Bowman's capsule. Okay, so there will be a group of cells occupying this empty space, which is the Bowman's capsule, and will surround the glomerulus. It looks like a crescent. Okay. The third name is antibody-mediated glomerulonephritis. So we have RPGN because this is a clinical course, crescentic because this is a pathological identity for it, and the third is a pathogenesis through antibody-mediated. We have three subtypes. First, the anti-GBM disease, where the abnormal antibodies, which are called the anti-glomerular basement membrane, will attack the glomerular basement membrane. This is abnormal. These patients will develop these antibodies that will attack the glomerular basement membrane and will make a local complex, a local immune complex, and consequently there will be a very local immune complex deposition inside the glomeruli with some consumption of complement in situ, but the remaining level of the complement in the body will be normal. So there will be normal complement in the serum, I mean. The second pathogenesis that we will develop immune complex. There will be abnormal antigen and abnormal antibody in the circulation, and both will they will make a immune complex together in the circulation, and they will consume complement, they will fix complement in the circulation, and at the end of the day this immune complex with the antigen, antibody, and complement will be deposited in the glomeruli. So there will be consumption of the complement in the serum. This is the second issue. The third topic or sub-entity of this type of GN, there will be only abnormal antibodies called anti-neutrophilic cytoplasmic antibodies. And this ANCA will be deposited inside the glomeruli, just an antibody. So clearly there will be no immune complex. For that reason it's called post-immune, the small level of immune complex, post-immune GN or ANCA-associated GN. Of course, this type will have normal complement inside the serum because no immune complex will be formed. It's mere antibodies. Okay, so don't forget these three subtypes of antibody mediated. We'll discuss this in more details. So we have these three types. First, the anti-GBM. The anti-GBM will have two, either these immune complex, these abnormal antibodies will attack only the basement membrane of the kidney, or the basement membrane together of the lung. So this will be the Goodpasture syndrome. So it is only anti-GBM GN, it's GN only, or it is GN plus lung hemoptysis as in Goodpasture syndrome. The second is the immune complex, and this under this title we have a plenty of diseases. We have the post-infectious GN, we have the lupus, we have the IgA nephropathy, we have the Henoch-Schönlein purpura, and others. And lastly, the post-immune. Let us discuss the post-immune GN. First, the ANCA-associated GN. This abnormal antibody will be deposited in the glomerulus only. So there will be ANCA GN. If it is deposited in the kidney as well as the blood vessels of the skin, so there will be microscopic polyangiitis. If we add on these two granuloma of the respiratory tract, so we will develop the vaginal granulomatosis. If we add on top eosinophilia and and bronchial asthma, I mean eosinophilia and bronchial asthma together with all these items, GN, vasculitis, respiratory granuloma, together with eosinophilia and bronchial asthma, there will be at the end of the day this syndrome, which is the Churg-Strauss syndrome. Again, the pathology would like best to take the idea of the pathology, not the detail of the pathology. This is the normal diagram of a normal glomerulus with a basement membrane lined by the endothelial cell, this yellow structure, and the epithelial cell, which is covering the basement membrane from the exterior. And this is the food processes of the podocytes. And there is a third player here, which is a mesangium between the glomerular capillary cutoff. There is a mesangial cell, and this light gray matrix is a mesangial matrix. So this is the structure of the normal glomerulus. We have to know for each pathological changes two items. We'll concentrate on two items. Don't be perplexed with details and forget the main topics. First, we have to concentrate on the distribution of the pathology and what is the morphology of the pathology. In the distribution, we have to know these four terms: focal versus diffuse. Focal means few glomeruli are affected. Diffuse means that all glomeruli are affected. In a more precise term, focal for less than 50% of the glomeruli, diffuse for more than 50% or equal to 50% of glomeruli. Again, the other two terms which are also opposite to each other, segmental versus global. If you concentrate on one affected glomerulus, if the affection is in a segment of the glomerulus only, so the term will be segmental. If the whole glomerulus is affected, so the term will be global. So this is the distribution of the pathology. So what are the pathology? Also focus on these few terms. First, proliferation. Proliferation of the three types of cells that I just mentioned: endothelial, epithelial, and mesangial. We are talking just now, since few seconds, about the proliferation of the parietal epithelial cells of the biomass capsule that will be to the crescents. So this number one, proliferation. Don't forget proliferation. Second, leukocytic infiltration. Leukocytic infiltration by neutrophils and monocytes in most of the pathology. Number three, basement membrane thickening. Why basement membrane thickening? Because of the deposition of the immune complex. Okay, so these are the three main items in the morphology, what we are seeing: proliferation, infiltration, basement membrane thickening. Other two terminology that you can take an idea about: necrosis, which is cell death; sclerosis is a scarring of the glomerulus. Type. What we are talking now are what we are seeing in the electron microscopy. The past is a light microscopy. Now we are talking about the electron microscopy. We will see thickening of the base membrane with the deposition. Where is the deposition? Whether it is subendothelial, subepithelial, mesangial, or even intramembranous. And the immune complex will concentrate about the immune fluorescence, microscopy will concentrate on what is the site of the immune complex deposition, whether it is linear or granular, and what is the type, whether IgG, IgM, IgA, C3, C4 light chain. Linear, as in anti-GBM disease; granular, as in post-infectious immune complex GN. And this diagram shows this. This is a linear. Imagine that it's continuous, as you are drawing by a line, continuous line. This is a line because there is attacking of all the base membrane. Here it is granular deposition. This is a spot, this is another spot, this is another spot, 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 spot. So it is in spots or in granules, as an immune complex disease: lupus nephritis, post-infectious, IgA. All these will develop into granular. And these are examples for the terminology. It's not returned. What will be the management of acute GN? The management entails diagnosis and treatment. Diagnosis by the clinical picture, as we just mentioned. By the urine examination, you will see the nephritic sediment, dysmorphic RBCs, and red blood cell cast. You will find the renal function deterioration in renal RPGN. You will test for the cause, so as to know what is the original cause and treat the cause first. We have to do anti-streptolysin otitis. If you guess that it is a post-streptococcal, you have to search for a viral infection if you suspect this as a cause. You have to search for these immune markers. If you are suspecting lupus, as in you will do anti-double-stranded and anti-neutrophilic antibodies. If you suspect ANCA associated, so search for ANCA. If you suspect NGBM disease, so search for NGBM disease, complement 3 and 4. And at the end of the day, renal, the biopsy will be the conclusion. What will be the line of treatment? Just the line of treatment. First, treatment of the cause. Treatment of the symptoms. We have fluid overload, so you have to restrict salt, water, give diuretics. We have to control blood pressures. The target should be less than 130 the systolic and 80 for diastolic. Start by diuretics, then stepwise add on therapy by beta blocker plus or minus calcium channel blocker. The AC will also have antiproteinuric and antifibrotic effect, but may aggravate the renal impairment, so take care. The main line of treatment being its immune complex, it's immunologically mediated, so we have to give steroids, immunosuppressant. Sometimes we have to separate this immune complex as in plasmapheresis. And if the patient has AKI, you will dialyze your patient. And this is a reference for our talk, and thank you very much.